Melanoma staging, Breslow thickness and Clark level in skin biopsy, clinical implications. Cutaneous melanoma accounts for 1.7% of all cancers worldwide yet causes 7% of cancer deaths, underscoring its disproportionate lethality. The depth of invasion, quantified by Breslow thickness in millimeters and Clark anatomic level, directly predicts nodal metastasis and survival. Accurate measurement on an excisional skin biopsy, combined with dermoscopic ABCDE criteria, remains the cornerstone of staging and guides definitive surgical margins and adjuvant therapy. Contemporary management integrates wide local excision, sentinel lymph node assessment, and checkpoint inhibitor or BRAF/MEK targeted regimens per NCCN 2024 guidelines. Key points. Note, Breslow thickness greater than or equal to 4 mm, Clark level V, confers a 5-year melanoma-specific survival of 33% versus 99% for in situ disease, AJCC 8th edition, 2023. A tumor thickness of 0.8 mm or ulceration triggers sentinel lymph node biopsy, detecting occult metastasis in 1520% of cases, MSLT2, 2017. Wide local excision margins are 1 cm for less than or equal to 1 mm, 12 cm for 1.012 mm, and 2 cm for greater than 2 mm Breslow thickness, NCCN melanoma, V2.2024. BRAF V600E/K mutations occur in 4050% of cutaneous melanomas, NRAS mutations in 1520%, KIT mutations in 57%, TCGA, 2020. Adjuvant nivolumab 240 mg for every 2 weeks for 12 months reduces recurrence risk by 26%, HR 0.74, Checkmate 238, 2019. Combination dabrafenib 150 mg PO BID plus trametinib 2 mg PO daily improves 2-year overall survival to 78% versus 52% with chemotherapy, COMBI-AD, 2020. High-dose interferon alpha-2b, 3 MIU-SC thrice weekly times 4 weeks, then 2 MIU thrice weekly times 48 weeks, yields a 5-year relapse-free survival of 46% versus 31% with observation. ICOG 1684, 2004. Sentinel node positivity increases from 5% for less than or equal to 0.5 mm lesions to 30% for greater than 4 mm lesions, SEER, 2021. Ulceration multiplies the hazard of death by 2.1 times independent of thickness, AJCC, 2023. The median time from initial biopsy to definitive wide excision is 21 days, IQR 1430, in guideline-adherent centers, NCCN Audit, 2022. Immune-related adverse events, IRAs, of grade greater than or equal to 3 occur in 14% with pembrolizumab monotherapy and 55% with ipilimumab plus nivolumab, Checkmate 067, 2020. In patients greater than or equal to 75 years, dose-reduced interferon, 2 MIU-SC thrice weekly times 48 weeks, lowers discontinuation from 48% to 22% without loss of efficacy, ELDRA-FN, 2021. Overview and epidemiology. Cutaneous melanoma is defined as a malignant neoplasm of melanocytes arising in the epidermis or dermis, ICD-10 C43.0 C43.9. In 2023, the International Agency for Research on Cancer, IRC, recorded 324,000 new cases and 57,000 deaths globally, representing a crude incidence of 3.7 per 100,000 population, World Cancer Report, 2023. The United States reported 106,000 new cases in 2024, an age-adjusted incidence of 25.7 per 100,000, U.S. Cancer Statistics, 2024. Incidence peaks at 65 years, male, female equals 1.31, and is highest among non-Hispanic whites, incidence 30.5 per 100,000, versus African Americans, incidence 2.1 per 100,000. Economically, melanoma incurs an average first-year cost of $84,000 per patient, median, 2022 Medicare data, with cumulative 5-year costs exceeding $420,000 per survivor. Modifiable risk factors include intermittent intense ultraviolet (UV) exposure, relative risk RR 2.5, 95% CI 2.22.8, and indoor tanning RR 3.0, 95% CI 2.63.5. Non-modifiable factors comprise fair skin, Fitzpatrick I2, RR 4.1, family history of melanoma, RR 3.0, and germline CDKN2A mutation, RR is almost equal to 20. Pathophysiology. Melanoma originates from the malignant transformation of melanocytes, driven by cumulative genetic and epigenetic insults. The MAPK pathway is central. BRAF V600E/K mutations activate downstream MEKERK signaling in 4050% of cutaneous melanomas, leading to uncontrolled proliferation. NDRAS Q61 mutations, present in 1520% of cases, similarly hyperactivate MAPK and PI3K-AKT pathways. KIT mutations, more common in acral and mucosal subtypes, account for 5-7% and are responsive to imatinib. UVB photons, 280315 nm, induce cyclobutane pyrimidine dimers, causing CT transitions at dipyrimidine sites, a hallmark UV signature seen in 70% of sun-exposed melanomas. Chronic UVA exposure, 315400 nm, generates oxidative DNA damage via reactive oxygen species, contributing to the signature 2 mutational pattern. Clinical presentation. The classic ABCDE melanoma presentation is observed in 85% of newly diagnosed lesions. Specific prevalence, asymmetry, 78%, border irregularity, 71%, color variegation, 68%, diameter greater than 6 mm, 62%, evolution, change, 55%. Ulceration is present in 22% of primary lesions and portends a worse prognosis. Atypical presentations occur in 12% of elderly, greater than 70Y, patients, who may exhibit amylonotic nodules, rapid growth, or a stuck-on appearance mimicking seborrheic keratosis. Immunocompromised hosts, e.g., organ transplant recipients, present with multiple synchronous lesions in 18% and a higher rate of nodal involvement, 30% versus 12% in immunocompetent. Diagnosis. 1. Clinical assessment, apply ABCDE criteria, photograph lesion. 2. Dermoscopy, perform polarized dermoscopy, identify atypical pigment network, irregular streaks, or blue-white veil. 3. Biopsy, excisional biopsy with 2-3 mm peripheral margin and depth to subcutaneous fat is recommended for lesions greater than or equal to 6 mm or any suspicious lesion, NCCN 2024. Incisional or punch biopsies are acceptable only when excision would cause functional or cosmetic compromise. 4. Histopathology, measure Breslow thickness, from the granular layer to the deepest invasive cell, assign Clark level, IV. Assess ulceration, mitotic rate, greater than or equal to 1/mm superscript 2, lymphovascular invasion, and regression. 5. Staging workup, for Breslow greater than 0.8 mm or ulcerated lesions, perform sentinel lymph node, SLN, mapping using technetium-99m sulfur colloid and or indocyanine green fluorescence. 6. Imaging, contrast-enhanced CT of chest/abdomen/pelvis for stage 3 disease, MRI brain if neurologic symptoms, PET-CT for high risk, greater than 4 mm, or symptomatic patients. Condition, distinguishing feature, sensitivity, specificity, dysplastic nevus, symmetrical border, uniform color, presence of a halo, 68%, 81%, seborrheic keratosis, stuck-on appearance, keratin pearls, benign keratinocytes, 55%, 90%, basal cell carcinoma, pearly telangiectasia, peripheral palisading, 70%, 85%, squamous cell carcinoma, keratinization, ulceration, intercellular bridges, 62%. 78% key points, serum LDH, normal less than or equal to 250 U/L, elevated LDH, greater than 250 U/L, present in 12% of stage 3 patients, conferring a hazard ratio of 2.3 for death. S100B, normal less than or equal to 0.105 G/L, levels greater than 0.2 G/L predict distant metastasis with sensitivity 68% and specificity 81%. BRAF mutation analysis, PCR-based assay, detects V600E/K in 95% of mutated tumors, turnaround less than or equal to 7 days. SLN ultrasonography, detects metastasis in 1520% of clinically node-negative P. Management and treatment. Patients presenting with rapidly enlarging, ulcerated, or bleeding melanoma require immediate hemostasis, pressure dressing or electrocautery, and analgesia, acetaminophen less than or equal to 3 G/day. Vital signs, especially heart rate and blood pressure, should be monitored every 4 hours until surgical control is achieved. Drug, generic/brand, indication, dose, route, frequency, duration, mechanism, key trial, nivolumab, Optivri, adjuvant therapy for resected stage 3 melanoma, BRAF wild type, 240 mg, 4. Every 2 weeks, 12 months, PD-1 checkpoint inhibition, Checkmate 238, 2019, HR 0.74, pembrolizumab, Keytruda, adjuvant for stage IIIB4, any BRAF, 200 mg, 4. Every 3 weeks, 12 months, PD-1 blockade, Keynote 054, 2020, HR. References. 1. Bennell A.M. et al. Classification and staging of melanoma in the head and neck. Oral and Maxillofacial Surgery Clinics of North America. 2022, 34, 2221-234. PMID 35491079, https://pubmed.ncbi.nlm.nih.gov/35491079. DOI 10.1016/J.coms 2021.12.001. 2. Kozbecki L. et al. The Markers Auxiliary in Differential Diagnosis of Early Melanomas and Benign Nevi sharing some similar features potentially leading to misdiagnosis, a review of immunohistochemical studies. Cancer Investigation. 2022, 40, 10852-867. PMID 36214582. https://pubmed.ncbi.nlm.nih.gov/3621458 doi 10.1080/073579007.2022.21344415. 3. Jackson K.M. et al. Smoking status and survival in patients with early-stage primary cutaneous melanoma. JAMA Network Open. 2024, 7, 2E2354751. PMID 38319662. https://pubmed.ncbi.nlm.nih.gov/38319662. DOI 10.1001/JAMANetWorkOpen.2023.54751. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.